this particular topic will be about joint replacements, which is a huge topic. You know, nationwide, we're already looking at about between 3 and 350,000 joint replacements a year, and the best predictions are in the next half decade to 7 years, it's going to be about 500,000 a year. So it's very, very common. It's not a new concept. The technology is changing, but joint replacements have been around for 30 years. Everything gets better every year, of course. Materials get better, and surgical techniques improve. But it's a real common ailment, if you will, or disease process. And the goal of this discussion is to make sure everyone understands that you don't have to give up your hiking, your biking, necessarily your skiing, and that there are alternatives in this day and age to kind of have your cake and eat it too. So I'll try to keep this very informal, and if honestly, if questions come up along the way, we can slow down, speed up, stop, anything. So I've been in Montrose for 14 years now, and as Mark generously went through my bio, I came from Denver, and so I started in New York and then went to Michigan and then Denver and here, and I have no intent of leaving or going any further, actually. So this is just a brief outline of what to expect in the next 45 minutes to an hour, depending on how we move. We'll go through what the hot topics are, what you do about them, what to expect from them. These are joint replacements. And then the project that I'm involved with is in Montrose, which is a concept that came out several years ago, and which I think has really streamlined care, made it much more predictable, and with ideally better outcomes and more predictable outcomes. A lot of people use the term arthritis. It's very generic. You know, people, without having ever had anybody tell them, they'll get up in the morning and say, I got arthritis. And a lot of people do. In your 40s, yeah, you take Advil a little more often, and you assume that you have arthritis. The term is very, very basic. Joint inflammation. Keep in mind that's an entire spectrum. You can have a little bit of wearing of a joint, and that's technically arthritis. You could have complete bone on bone, and that's arthritis. And there's everything in between. So every time you hear that term, it doesn't mean a catastrophe. It doesn't mean you have to have something fixed or a surgery. You don't even have to meet a surgeon necessarily, which would be nice. The most common form of arthritis is osteoarthritis, which is typically degenerative or wear and tear, you might hear. Sometimes it's post-traumatic osteoarthritis. You know, I had a ski injury 10 years ago. I had a couple minor surgeries, and now my knee's getting stiffer, swollen. That would typically be post-traumatic osteoarthritis. And then sometimes you just pick the wrong parents. You know, my dad had a knee problem at 65, my mom at 75, and here I am, I'm having a knee problem. I've never been injured before, never had a surgery. Why me? Degenerative arthritis. And then there are quite a few, and going down the common list here, it becomes less common. And there's a lot of other ones beyond that. Inflammatory arthritis, meaning they're blood-borne forms of arthritis, sometimes treatable with medications, such as you see rheumatoid, psoriatic, and in the case of septic, it's having a joint infection that leads to breakdown of the joint surface and consequently bone rubbing on bone. So these are all reasons why you would consider doing some sort of restorative procedure, such as a joint replacement, or you may have heard the term joint resurfacing, and there's some subtleties there. So going back to the general term, joint inflammation. Ideally, all of our mobile joints will be covered with about a 2 millimeter thick layer of what's called articular cartilage. That's a smooth, white, glistening cartilage, and everything would glide, and our joints wouldn't pop and crack and that kind of thing. But what happens is when you start to wear down for any number of reasons, as we pointed out previously, you start losing that congruency, and you start thinning that joint surface, and then you're left with this joint that has some pitting, and consequently, when you have an irregular surface rubbing on a regular surface, for example, the surface below, eventually they're both going to go. Two irregular surfaces, they wear against each other. Hips, knees, shoulders, those are the most common ones, but in this day and age, people are replacing wrists, ankles, little finger joints. It can happen in any joint. the images on the left is the one that you would prefer to have your entire life. It'd be ideal to have joint surfaces that always looked smooth, a knee, in this example, that always moved well and it was symmetric with the opposite side and was the same one you had when you were 15 years old. But that's not always the case. On the right, you see these knees have seen better days. You can actually look at this image and say whether it's post-traumatic arthritis, osteoarthritis. But you know that clearly compared to the left, you're narrowing your joint space, you're wearing out your surfaces. You can see some bone spurs in a number of areas developing.
Point them out.
Do you have a pointer by any chance?
Point out the bone spurs.
No, that's all right. So a bone spur is something like this. You start developing an extra area of bone, and a lot of times you'll see it on the top one or the top of the kneecap and over on the side. And bone spurs are just your body's attempt to try to broaden the surface area, redistribute a load over a broader area, so there's less load per unit area. And so that's very common in all our joints. When joints start wearing out, they get a little thicker. If anybody here has got a degenerative knee, if it gets a little wider, maybe you can feel little bumps that weren't there some years ago. It's a very common occurrence. So the previous slide was an osteoarthritis scenario. This is more an inflammatory arthritis. So you don't see the same extra bone forming, but you are seeing is narrowing of the joint. So it narrows without all that extra stuff and all the irregularity. And you can see that in the central image. It shows narrowing of the joint. This is something more likely associated with rheumatoid arthritis. The hints that it's also rheumatoid arthritis is a lot of times these patients will have a much longer progression. They'll have swollen joints from early 20s, 30s perhaps, for no reason. Sorry about that. Okay. So it's fairly common, in the single most commonly performed arthroplasty procedure. So arthroplasty means joint plasty's reconstruction. So the most common nationwide joint reconstruction procedure is a total knee replacement. That's what this is. Total knee means you're replacing all the interfaces in a knee. And if you visualize the knee on the left once again, you can see on the far left, that's the outside half of the knee. There's the inside half. And on the one just to the right of that, it's a side view of the knee. There's the kneecap rubbing on the femur. So those are really the three joints within the knee. And what exists today is you can replace one or the other. Sometimes you replace 2 out of 3. When somebody needs the whole thing done, that's what's called a total knee arthroplasty. So, and we can review, there's a model over there that'll show that as well. So these 3 images on the right demonstrate we've replaced every interface. So there's nothing left from that knee that can possibly rub bone on bone. So what's the bearing surface is the metal component, which is cobalt chrome, and that's all the vendors in the country, every company, and whether it's hip or knee, all use similar materials, cobalt chrome. The actual bearing comes between the cobalt chrome and high-density polyethylene, which you don't see on the x-ray, but you can deduce it's there because of that little clear space between the 2 components. On this bottom view, that's a view across a bent knee showing part of the kneecap with a little clear space. What's on there is a little polyethylene button that rides in on the femur. So there's no further bone on bone. And we'll see some images of a partial knee replacement. So this is somebody who perhaps only had one area of their knee injured or worn down, like you see in the far left slide. And the technology exists to just replace the part that is injured, or as my chairman used to say, go where the money is, so to speak. If that's the only problem, this person otherwise has a perfect knee, maybe you don't have to replace the whole thing. Potential advantages of a partial knee is we allow people to be much more athletic. You could do more cutting, pivoting sports, which is a big deal in this area here. Complete knee replacements don't withstand as much shear stress as these partial knees do, so most of us are much more cavalier about letting this patient jump off of things and ski hard rather than a complete knee. That being said, I know a lot of my patients still do that, regardless of what I say. Moving to the hip, you can see on that left slide the differences between a fairly normal hip, which is on the far left, compared to its neighbor in the central portion of that slide. What's happening is that person's wearing out the ball and socket. Common symptoms of that are people say groin pain. I have trouble getting out of a car. I sat in this lecture for half an hour and I got up and it took me a while to get going, to get straight. We very commonly call that startup pain. Pain the first couple steps when you get going in the morning, out of a car, getting up from the dinner table, that sort of thing. And very commonly loss of rotation. There's a couple different current solutions that we'll go through. One is called a total hip arthroplasty, just like in a total knee. A total hip means you're replacing both the socket and the ball part. And the way you hold everything in place, in the case of the knee that you saw, we typically will use bone cement to hold the components in so you can actually walk on them immediately. You do the surgery on a Monday morning, a lot of people are up walking Monday evening. Same thing with these hip replacements, but the way these work is instead of cementing them in place, your femur is hollow and you actually put that stem inside the femur, which gives it rotational stability and longitudinal stability. The interface between that ball, you can see there's a lot of overlap because they're made of metal, but there's a ball and then a socket and then a polyethylene layer, and we can see that in a model later, and that's where the motion comes from. Most people think of a shoulder as a ball and socket, but when you look at it, it really isn't. It's more, visualize more of a golf ball sitting on a tee. The socket's very shallow, and so it doesn't have the same solution as our other joints. It begs the question, what keeps that ball on that golf tee? Because there's no containment like in a hip joint. And what keeps it there are the ligamentous complexes, a really thick group of ligaments that holds that ball onto that golf tee. And it makes it a little more challenging. You have to reconstruct all the things that you don't see to make a shoulder replacement. And it requires that a person who needs a shoulder replacement has an intact rotator cuff or a group of muscles around the shoulder. This is a fairly normal shoulder. This one not so much. So classic history or physical examination on this person would be pain reaching in front of them, overhead, grinding with any sort of lifting. And what you do find is that people have more problems when it's their dominant arm. If you can do the vast majority of things with your dominant arm. If it's your left shoulder, somebody who has shoulder arthritis can go many, many years with a shoulder that doesn't move very well. But the second you put that in a dominant arm, they hate it because or they have to adapt. So some of the technology is similar to the hip. You utilize the fact that the humerus or the upper arm bone is hollow. So this device or this stem would go inside that hollow part. And then that ball attaches, and then it sits up against the socket or the golf tee, as I alluded to, with a polyethylene component as well. And again, you need all the ligamentous structures to hold it in place. But all three of those, and you saw the one of the partial knee, every single joint replacement is skyrocketing in terms of frequency that it's getting done. And that's a combination of naturally aging demographics. Everyone's heard the term baby boomers, and that's the subgroup of active people now in their 60s that has both a longer life expectancy and a greater expectancy of lifestyle too. Now, you could look back a couple generations when somebody was 65, I could tell you they weren't skiing 40 days a year and rock climbing and doing all this stuff, but they are now. I certainly have 80-year-old patients who are still skiing and still hiking. And so it's a combination of greater expectations later in life, I believe, as well as the true fact that our population in general, the curve of our average population is going older. So, and that's the reason why the number of joint replacements done nationwide is going through the roof. And even in our relatively small hospital in Montrose, from when I moved here to this past year, it's gone from, and Dean can give you the real numbers, currently it's about 200 a year, and we fully anticipate it'll go well beyond that to 200-300 in the next couple of years. The hot topics, everybody wants minimally invasive. Less is more. You know, we do a lot more things these days through scopes, fiber optics. The design rationale of these different prostheses, what used to make an incision this big, you can now do an incision this big, and we use live X-rays to assist. So that has always been a trend. And then what comes along with that is a change in the prosthesis or the implant, and then the instruments they use to put them in. So the whole nationwide and worldwide trend is towards less invasive, less muscle trauma. It's bad enough this person has a worn out joint, but on top of that, do you really want to traumatize them further to put the new joint in? If you can muscle spare and minimize the postoperative pain, they're going to be happier people. A lot of energy and time and money has been put into direct-to-consumer advertising. A couple of years ago, you couldn't open up a magazine and see Arnold Palmer trying to sell you a hip replacement. Now that exists, and Jack Nicklaus has a hip, and I don't know who else. And on top of that, gender-specific. So now I have patients who come in and say, I want that women's knee, the one that works better. I say, oh, that's a farce, because they say that the company says, well, this women's knee, it bends better. Then you have the guy come and says, well, I want my knee to bend too. Can I have that knee? It's actually, these companies have always made multiple sizes for different sized people. So you might have a larger woman and a smaller guy, and they use the same prosthesis. So when you're flipping through a magazine and you say this is the woman's knee, you don't actually, everyone gets that anyways.
And that's not the case with hips?
That is also the case with hips. So the materials are all the same weight, so you don't actually put a lighter prosthesis in a lighter person. Typically the lighter person, or the more slightly built person, uses a smaller size, and consequently it's a lighter material anyways, because it's just a smaller size. But it's not a men's hip, a women's hip. We tend to base decision making more on physiology. You know, if I have a 70-year-old person who's running, I'm going to use a ceramic component perhaps rather than a sedentary 70-year-old person. So I'm going to base decisions on physiology, expectations, and what their body is, rather than their age or their sex. So this is true. Just about every surgeon uses the best technology for that problem. So a patient doesn't have to come in and say, I want the knee that bends farther than my neighbors. Everybody gets that, of course. We want everybody to bend farther than their neighbors. We'll have a couple of slides that review the bottom two, mobile bearing designs. There's some new philosophies on having sliding polyethylene to decrease wear. The art is always to be able to make one procedure last forever, and that has always been the goal from the 1960s when joint replacements were first getting started. We would love to have this conversation and say, we're going to do this once, we're going to do it right, and you'll never have to talk about it again. The reality is, we're not quite there yet. The materials just aren't there, and a 50-year-old, 50-time-a-year skier is putting a lot of load on a joint, and we have to face the facts that materials do fail. So different design rationales come out to try to deal with that.
So how long would you say that joint would last for that 50-year-old?
So a 50-year-old with current technology so you'd use ceramics and cementless technology, I think realistically it would last probably 15 years for a hip replacement. But the second part of that discussion is, okay, we as surgeons do our best to try to plan, okay, we're going to do this once, but if not, what's the plan B so that we don't have a catastrophe 15 years down the road, and try to plan the next 30 or 40 years. And what has changed over the last few decades is the concept of modularity. What that means is that when you put a hip replacement in, for example, you put a cup in, and then you put a liner in that cup, and then you put the stem in. Well, that liner is interchangeable, and that's the bearing surface that wears out. So conceivably, if somebody gets their money's worth out of this hip, and they play and they run and they all do all this fun stuff and they love it, you keep an eye on it over years. Every 2 years I mandate, even if people feel well, I beg them to come into the office, shake hands, get an x-ray, and you look. And if you see that polyethylene layer is wearing, you can actually switch that out without changing the whole thing. So the concept of modularity means you can change parts without having to change the whole thing. So in essence, we hopefully can take the original prosthesis and truly make it last forever. with a little, timing belt change every now and then and so forth. And then maybe someday the perfect material will come along, will truly last forever. Same thing. If you read newspapers, magazines, or surf the internet, you'll hear the term hip resurfacing. That's a concept that's been out for the last 5 or 7 years. Floyd Landis got one of these. I think he had a lot to do with the advertising. It's a very specific subgroup of people who, typically men, because there's very few sizes. And it's a concept by which you don't remove the entire head, but it's actually not minimally invasive, it's maximally invasive. This is actually more invasive than that larger piece of metal you saw. But you'll hear the term, people will come in and say, well, do I need a hip replacement or a hip resurfacing? It's really the same concept. And what you're doing is replacing the ball in the socket. This one just happens to spare a little more bone. And the idea being, by doing so, you save bone so that down the road you can do another procedure if you needed to. I took the course in this and I didn't like it. It made me nervous. It was such an aggressive procedure. But that being said, there are places in the country where they do a lot of these. Hip resurfacing. So this goes back to the concept of different materials for different people. Not if I have a patient who's, let's say, 75 years old and golfs 2 days a week and goes for walks. Does that person need ceramic? And one thing that a lot of times in healthcare we're shy to speak about is the fact that we're heading towards, as I mentioned, 500,000 joint replacements a year, but we're also heading towards a time in healthcare where there's not going to be enough money to actually pay for 500,000 joint replacements a year. So there's at some point those two lines cross. And I try to have an honest conversation with people saying, okay, if I know here's your lifestyle, a conventional hip replacement, by conventional we mean a cobalt chrome or metal ball and a polyethylene socket. That's been around for years. It works wonderfully. That is going to outlast this person. If it lasts in that age group, unless they're running, which not a lot of 75-year-old people still run, you can make that joint last forever. And so you don't have to use fancy techniques, over-the-top bearing surfaces, because anything you do is going to be perfect for that person. Does that make sense? But for a lot of other people, everybody says, well, I want the latest and greatest. Sure. The one on the top is a ceramic on ceramic interface. The one in the middle is a metal on metal interface, which has gotten a lot of press lately. There was a recall, a company called DePuy, which is a very good company, a multi-billion-dollar multinational company, created this product called a metal on metal hip. The goal of which was for a younger population, because metal has a lower wearing characteristic than polyethylene. So that came out. Unfortunately, the best you can do is research these things in a laboratory setting, put it on a machine, cycle it millions of times and say, hey, this is great. But until you actually put it in real people and cycle them a million times, you don't know exactly what's going to happen. And so what happened was the metal on metal had some early failures, and they got a lot of press. And then nowadays with the same direct advertising, there's massive lawsuits and patients come in all the time saying, you don't use that metal. And I said, well, I don't think anybody does anymore. Well, everyone's scared to death. But it exists. And actually the metal on metal concept has been around for 30 years, and it gets refined. It's not a bad idea. It makes sense from a wear point of view, but it's a little scary now that people are identifying that people have higher ion levels, and nobody knows what that does. So the metal on metal is becoming less in favor. And then the bottom one is really a schematic of showing non-metal interfaces. So you see there's the one in the middle, that pink one, is actually zirconium or ceramic, and the other one is oxium, which is a metal alloy. What you typically find is there's very few surgeons who use 20 different kinds of materials. Typically you find a metal on polyethylene that you like, and in my case I find a ceramic that I like, and I say, you know what, I'm going to use those two, and then combine with a variety of different stems or the femur side, depending on somebody's activity level, expectations, and so forth. And one thing I didn't point out is that lately, since I moved to Southwest Colorado, where I trained, not a lot of people did yoga. which is a big deal. You think about it, because you'll say to somebody, well, the conventional hip replacement will give you, the ability to get up here, and out here. And most people say, wow, that's great. That's more than I've had in years. But then you have the person who does yoga, and they say, well, that's nothing. I want to be able to do this. So then you actually, there are prostheses now that you can actually put in more rotation, and you can actually test that while you're putting it in to make sure that somebody doesn't have a problem when they do what they really love doing. Shoulders, new ideas. Very similar to that hip resurfacing. This is the shoulder resurfacing. It's, again, bone sparing, smaller incisions, same concept. This one looks ridiculously invasive, and it is. And this is called a reverse shoulder. What we're seeing is a much greater number of people who have shoulder arthritis combined with a rotator cuff problem. And again, I think the reason is people have greater expectations. I think a generation ago, if you couldn't lift your shoulder up, you said, that's the way life is. I can't lift my shoulder up. I don't do it that way anymore. I put all my dishes on the lower level or something like that. But that's not so true anymore. Now, this is a common thing I see on every week I see this. It's somebody who has a long time existing problem that's been going on for 20 years, and now I'm tired of it. Now I can't reach. I can't get my shirt on. I can't get my blouse on. And you cannot, in this scenario, do the conventional shoulder replacement, because with a rotator cuff absence, it has a much higher failure rate. So a device has come out in the last decade called a reverse shoulder. They call it that because what you'll see in that middle slide is that you put the socket, or I beg your pardon, you put the ball on the socket side, and you put the socket on the ball side. So you've turned around a natural shoulder. And the reasoning is what that allows you to do by changing, it's biomechanical, but by changing the center of rotation, it actually allows you to use your deltoid, which is still functioning, to raise the arm. So you can take somebody who can only do this and get them to do this, and by and large, they're happy people. As long as you tell them that it's not a power joint. You cannot start pitching or throwing curveballs or getting in snowball fights. So all this whole concept, the number of joints going up, the need for the expertise, led over the past few years to the creation of a joint center. The concept has been around for a while, and the concept is you put all these like-minded people. This guy needs a knee replacement, she needs a hip replacement, this guy needs a shoulder replacement, but they're all sort of in the same boat. They're all undergoing the same problems. And instead of having them spread all over this hospital, you put them together. And what you find is when you put 3 or 4 or 5 or 6 people together, they actually do better in each other's company. They may not even know each other, but by getting up in the morning and saying, how's your shoulder, how's your knee, it feels good, we're going for a walk together, or something along those lines. It was the concept of a joint camp, and that was tested in university settings even when I was a resident a few years ago. And so what that's led to in our area now is the standardization of having the same therapist do the joint recovery, the same anesthesiologist doing it. We tend to do all our joint replacements on the same days, Mondays and Tuesdays, and so all these people progress. And I think what we're finding is that they build up that camaraderie and actually thrive on it. In the past, when we first moved here, you would do a hip replacement on a Friday, and they'd be in one wing of the hospital, and then a knee replacement on Monday, and they'd be here. And they did fine, but they all had different therapists. Different therapists sometimes have different philosophies or different styles, and that may have worked for some people, but this concept seems to make sense. And quite honestly, it allows you to do it at a better cost, and hopefully that prepares us for the next decade or two. The concept of joint center or joint camp. What we've put a lot of emphasis on is the education before. Before you ever get to the point of having a joint replacement, you already met your anesthesiologist, you know what's going to happen. You've met, obviously, the surgeon, you've met the nurses, the therapist, and so the day a person has surgery, they walk in and they go, okay, I recognize this place, I've been here before, I know what's going to happen, and it takes a lot of the anxiety out of it, and you can focus on actually the recovery part. Dean's the director of the Joint Center, and as he'll tell you, and he can brag later, it's over the course of a year has scored the highest marks of any, am I lying? The highest marks of any department within that environment in the hospital. So it works. It works for the patients, and they seem pretty happy. We can read all this. This is usually what it takes when somebody walks in the office and says, "Okay, I'm ready. I want a new knee." They don't actually get the new knee that day. Then it triggers a series of events, and so typically it's about a 4 to 5 week lag from the time somebody chooses to do it. There's exceptions, obviously, but to do it properly, you line up everything so by the time when the day comes, it's easy. The education, I'm a big fan of prehab, and I know that's an increasingly common term where you rehabilitate somebody before they've had surgery. And quite honestly, that's going to become, and already has become, more common in non-replacement shoulder surgery, knee surgery, and a number of other things. The more educated and the better condition somebody is going into it, the more graceful the recovery is. And I truly believe that. A lot of times, who benefits from these classes beforehand is actually the spouse or the significant other, because very commonly when you're at home and you're exhausted and you just had a big operation, it's your caregiver who everything falls on. And the more educated that person is, the more graceful the whole recovery is. So that's the concept of having a coach and establishing that caregiver relationship. All our patients now get a lot of education on the front end, and it might be overwhelming, and that's part of the reason why you lag a little bit. You give them this big booklet, and they take notes, and they go to these classes, and they meet all the anesthesia people, and then their head's spinning. So you write all these things down, and we go over it. So by the time surgery comes, everybody knows everything. Dean has a copy of this back there. We can look at that. A couple points that we've consolidated as we are now 5 surgeons in Montrose and have juggled the schedule such that everything gets done. It's a long day, and for our operating crew, we have to make sure we keep showing them the love, because we ask them to do usually anywhere from 6 to 8 joints in a 2-day period, joint replacements, and each one takes 2.5, 3 hours. So it's a lot of their time, and we have to keep everyone fresh, but it pays off, because I think the patients get maximum care during the week, and very commonly they're home by the weekend in their own homes. Pain management's a really big concept these days. You really can't give people a leather strap and a shot of whiskey anymore. They never liked it anyways. The big concept in a lot of orthopedic surgery is the concept of regional anesthetic. Regional meaning you just make the part go to sleep that you're working on. We really try to avoid general anesthetics these days. General anesthetics more often will give somebody postoperative nausea, vomiting, euphoria, they feel out of sorts, and then it takes away from the actual rehab part, because they spend a day and a half getting over all this stuff. So now what's in vogue, which really works, are these regional blocks, is a spinal anesthetic perhaps. In the case of upper extremities, an injection in your neck and your arm goes numb. You don't even have to go to sleep anymore. And for knees and hips, a lot of times we'll make just from the waist down go to sleep. And these anesthesia guys are pretty slick. They can make that last for 18 to 24 hours. And people may have heard the term walking anesthetic or walking epidural. The concept is you can make somebody go numb and still they don't lose motor function. So you will have no pain and you can still walk. That's pretty slick. So consequently, less narcotic requirements, side effects of narcotics, constipation, kind of feel goofy, appetite's off, drowsy so you can't rehabilitate. So now they're a little fresh, wide awake, happy. Yeah, people come in and say, do I have to have anesthesia? Yes. But anesthesia, I think people are thinking of general anesthetics. It would be cruel to do any of these without anesthesia, but regional anesthetics is the way to go, I think. And you meet them all beforehand. So some people say, well, a spinal, you're going to put a needle in my back? That sounds horrible. It's actually not. It's pretty slick. But if you hear that beforehand, you don't have the anxiety associated with it. Dean, what are these pictures of, aside from a room?
Basically, it's just showing of a private room. It's the shower set up so that they can get a visual understanding of what actually we have and what's going to occur.
Ah, yes. The days of recovering in a ward are long gone. Everything's large private rooms. You find that your nurse in the Joint Center comes by with a little iPad and says, what would you like for breakfast? It's better than any restaurant in town. And actually, the guy who runs the kitchen there trained at the American Culinary Institute, so it's oddly, it'd be a nice place for a first date if it wasn't a hospital. And you can see they're all ADA type showers because, you know, the goals are you try to fairly rapidly progress somebody to be in their own home environment. So that might mean on day 2, people get up, they get in the shower, they're retaught how to be independent. You take a lot of these things for granted. You know, when you have a hip or a knee replacement, you don't just bounce up and run to the shower like you normally would at home. You have to relearn a couple techniques and some safety, but it's all in the room. Therapy is right on site. That's just one piece of equipment. Dean, do you want to review some of your statistics?
Sure. I mean, if you want.
Do I usually do this, or do you normally do this?
You typically will.
See, okay.
Key spots you'll ask me if you want.
Okay, okay. It seems to be working. I don't think we as surgeons didn't do anything differently, but just through either word of mouth or creating an entity that did a procedure or a set of procedures better, the numbers rapidly increase. And I honestly think even with a downturned economy, it seems to be sustaining, and I get the feeling it's going to keep going up. I will say I'm worried that people are starting to come in and are thinking about doing joint replacement sooner because they have such a fear of healthcare collapsing. If that makes sense. People are saying, well, I think I can live within another 2 years, but I'm not sure what Obamacare or Affordable Health Care Act. And they say, well, why don't we replace it now in case it's not there? And I assure you it'll be there in a couple of years. Okay, now it's yours.
Thanks.
So, I'll come up front.
I'll sit.
Good evening. My name is Dean McCall. We put this in back in '09, as you can see in some of the slides, and we've just kind of gradually evolved with this. The most important piece that we've tried to achieve with this program is doing an evidence-based application so that we can see how our patients are performing, what happens and how they occur through the whole process, and then making adaptations to that. One of the things that we always try to do is visit with them each week that they come through, and we try to learn something from our patients, and everybody brings a different perspective, and then we try to integrate that. That also being said, in doing the evidence-based application, is anesthesia has an opportunity that with keeping the group together and everybody to come through and look and then see what the differential is that exists between that patient population. So they're making modifications on what they're actually doing. So for the whole team, it's a great place for us all to grow and continue to ask the question, what can we do differently? So we've put some numbers together, and what we've done in developing the program and designing is we did a primary care nursing model, which is very rare. You're not going to find that in most places, which means there's not a CNA on the floor. You've got a therapist there throughout the entire period for all the patients that are there. So it's a group and it's a team effort. You get a little bit more supervision. With that model, so it creates more of a boutique design for you. It's carved out as a niche. We know that joint replacements, it's an elective procedure. It can be done anywhere. And part of the growth of why we went for a growth of about 48% is we started letting people know that. You educate your community, you educate people in the primary market of where you're at and secondary market, and you say, what are we doing differently here of why you wouldn't want to have to go over the hill? We get a lot of calls on those types of things, and there's a multitude of different things that we're doing that produce a different outcome. And we have the ability, because of the size of the program and the committed staff, to make that move fairly quickly. You know, we can all look at bureaucracy and see how that moves. Fortunately, in our situation, we can make a change fairly quickly and adapt to that. So in the 2.5, 3 years that we've been open and operating with this, you know, we're 100% safe from injury. That's a pretty significant impact for people that are coming through. One infection, it was due to a fall after they went home. So the patient actually discharged from the program. I believe they're actually in a skilled unit. They discharged from the program, went to a skilled, fell at the skilled, opened. Obviously there's other issues that came. So that's a significant and important fact for people to know on that. 98% on the pain score. The gold standard globally is a 4 out of 10 score on a 1 out of 10 for pain. Because our anesthesia, our typical pattern, and Dr. Singh, you may want to correct me if I'm wrong, is about 18 hours post-op. Most of the knees and things, we're just going to use knees as an example, have an additional block to it, or they've been provided another anesthesia to help through that process. And then we transition to an oral med. different places across the country have different theories on that and perspectives. What we're doing with that piece is getting that front loaded with the nursing staff, because you will have the same nurse. We designed it to where the same nurse that gets you when you come out of the OR, you meet at your class, so you have a relationship with that person. That person's your day shift nurse for your entire stay. That swing shift nurse is your nurse for the entire stay. That night shift nurse is your nurse for the entire stay. They know you, they're involved with you, and they basically can make those modifications and changes, and this is all they do every week. So they see 200 plus of these every year. And they make those recommendations and they adjust those oral meds so that we stay pretty well in that 4 out of 10 range. And obviously when you're going to have a joint replacement, pain is a significant issue. That's what brought you there in the first place. The other scores down here on the 86%, 91%, and 98% partially met and met, we did a study that looked not just in our country but abroad. What were the key goals and the key things from a global, even in the European market, of what were the things you were wanting to achieve. We identified 10 key components with those goals, and that's how we then score them. The lower portion on the hip, one of the variables that you get on that is some of the older population may not hit some of those goals, and they may need to go to a skilled. It's a physically challenging endeavor to do a total joint replacement, function and hit those 10 different goals, and then transition out. But that's what we're looking at, with the measure being a 3-day period. Is that?
Yeah.
I think the next one kind of talks about HCAP scores.
Yeah, anytime all these acronyms come in, I get a little nervous. These are the scoring systems. Why don't you keep going?
Keep going on this.
Yeah, I don't really. You're the one who puts all these numbers together. I just work. I just work.
So the other thing you're hearing in the healthcare industry is what is going on across the country in regards to transparencies, how we understand how healthcare is delivered, which facilities are doing what, who's doing a great job, who's not. So one of the biggest drivers is this hospital consumer assessment of healthcare providers and systems. That actually goes to Medicare and CMS. That's what they're putting out and driving. So on a national scoring tool, we rank, which Dr. Singh alluded to earlier, in the top 2% in the country. We range somewhere between the top 1% and top 2% in the country over the last 3 years. For a small rural hospital, that's pretty significant. But it's relevant to the uniqueness of the program. Go ahead.
Is that specific to the Total Joint Center, or does it encompass all of one?
It is specific to the Total Joint Center. Those numbers and what I've carved out and done is all completely relevant to the uniqueness of this program. And the team's very proud of it. And they have a strong passion for what they do. And then the avatar scores down in here is basically patient satisfaction scores. Top box scores, if you know a bunch about data and things like that, that's a pretty important number to keep an eye on. When you're running about 80 to 90% of your population are giving you the highest scores on the charts for what you're doing for your care and service, that gives you an idea of where you're at in the program. Anybody got any questions on any of that? Okay.
I have one more question. What is the length of the stay in the hospital?
I'll say that. So it depends on the procedure. So for commonly, depending on what's 1 or 2 days in the hospital. Very commonly, if somebody has no one at home to help them out, we'll keep them an extra day, or we'll get a skilled nursing facility involved, because the worst thing we could ever do is send somebody home and have them struggle. You really haven't accomplished anything. So the short answer is 1 or 2 days for a shoulder replacement, a partial knee replacement 1 or 2 days, hip and knee replacements roughly 2 to 3 days. Again, depending on someone's physiology going into it. And quite honestly, our younger population, more and more we're doing replacements in the 50 to mid 50 population. They usually get up that day and say, when can I leave? You have to actually pull back a little bit. Does that answer? Sort of. It's a range, right? So and some people still have nausea, and if you miss a day because at first they just feel crappy, then it's going to be 3 days in the hospital. And then some people get up that same day, do their surgery in the morning, they get up and they feel great, and they go for a walk. They're probably going to go home the next day or two. So thanks for your time. There's plenty of time for questions. On that back table, there's a representative model of the different things we spoke about and some flip charts and things of that nature.